Hi, this is Dr. Wael Gendy, consultant of ophthalmology and head of the emergency department in the Memorial Institute for Ophthalmic Research. Today, I'm going to be talking to you about ROP screening, retinopathy of prematurity screening. By the end of this lecture, each resident should be able to define what ROP is, to identify neonates at risk of developing ROP, to recognize when to do the first eye exam, and should be able also to schedule their next follow-up. At the beginning of the lecture, I would like you to pause this video and screen this code or follow the link here so you can take a pre-lecture evaluation quiz to let us know the amount of knowledge you have on ROP screening. And by the end of the lecture, we will give you another code and another link to take a second quiz to allow us to understand how much knowledge did you gain from our lecture and how effective our lecture was. Retinopathy of prematurity is a disease that affects immature vasculature of eyes of premature babies. It can be mild with no visual defect, or it can be severe with visual disabling effects. 50% of premature infants weighing less than 1,250 grams at birth show evidence of retinopathy of prematurity, and about 10% of these infants develop stage 3 ROP, which is a blinding condition and a sight-threatening condition. The risk factors which defines who to screen are birth weight before birth age, gestational the risk factors that define who to screen is birth before 30. The risk factors that defines who to screen is birth before 32 weeks gestational age, especially before 30 weeks, birth weight of less than 1,500 or 1,250 grams. Possible risk factors include other possible risk factors include supplemental oxygen, hypoxemia, hypercarbia, concurrent illnesses like the need for blood transfusion and weight loss. When do we do our initial screening? Our initial screening is done 4 weeks after birth generally. But if the baby is born 26 weeks or less gestational age, we will have to do the examination at 31 weeks, even if it's further than 4 weeks after birth. So let me elaborate on this. If we have a child that was born, a neonate that was born at 29 weeks gestational age, we do the examination 4 weeks later, which is 33 weeks gestational age. But if the baby is born at 25 weeks, 4 weeks after gestational age, after birth, is 29 weeks gestational age. You cannot do examination at this age, so we wait and we do the examination at 31 weeks of gestational age. Babies born at 26 weeks will also receive their examination at 31 weeks gestational age. So we can do our examination 4 weeks after birth, but not before 31 weeks gestational age. When do we do our follow-up examination and screening? So after we see the patient at the initial screening, if we have a pathology in zone 1, then we do our next follow-up after 1 week or less. If we have a pathology of stage 3 in zone 2, we still do our follow-up after 1 week. Also, posterior immature retina and aggressive posterior ROP merits the follow-up in less than 1 week. Regressing ROP in zone 1 and stage 2 ROP and regressing ROP in zone 2, they deserve follow-ups within 2 weeks. Pathologies in zone 3 usually gets followed up in 3 weeks. The general condition of the patient has to be considered, because if the weight is deteriorating or even if stationary, this means that we might need to have a close follow-up and shorter periods of follow-up intervals. So to summarize, we screen babies with gestational age less than 30 weeks at birth, and who weigh less than 1,250 grams at birth, and any neonates that have concurrent illnesses that deserves the follow-up. Initial screening should be done 4 weeks after birth, but not before 30 weeks gestational age. Follow-ups could be done 1 week, 2 weeks, or 3 weeks intervals, depending on the pathology. Thank you very much for your attention, and I would like you now to scan this QR code also, or follow this new link to take a second evaluation quiz so we can evaluate the amount of knowledge you have gained from our lecture. Thank you very much.